Hello, and welcome to our discussion about cardiac implantable devices, including pacemakers and ICDs. You can view the objectives on your own. We will start the discussion with pacemakers, which are electronic devices that provide electrical impulses to the heart muscle. And this impulse will stimulate a response, so a heart contraction. Pacemakers can be temporary or they can be permanent. And they're used for symptomatic, chronic, or recurrent types of dysrhythmias that are unresponsive to other therapies. A situation where you may see a pacemaker is in the case of a severe bradycardia. Some heart blocks will need a pacemaker, some patients that overdose on drugs, and rhythms that the heart has lost its atrial kick, like a slow AFib, for example. There are many other reasons, but these are just some to give you an idea. In terms of modes, there are two basic types of modes that deliver an impulse to a patient when they have a pacemaker. There is a synchronous mode, which is also known as a demand mode, and this allows the heart to beat on its own, but the pacemaker will send an impulse when it detects the heart's natural rhythm is going too slow or if it stops. There are asynchronous modes, which are fixed rate modes. And this is when every beat is programmed from and delivered from the pacemaker. So if the pacemaker is set on 60 for a rate in an asynchronous mode, then the heart rate will always be 60. No matter what the patient is doing on their own, it recognizes its own self, its own pacemaker instead of the patient's. These are examples of what paced rhythms look like on a monitor. So on your far left, you see an atrial paced rhythm. I know this is atrial paced because there is a pacer spike, so that little blip before the P wave is a pacemaker spike. And you'll see that pacemaker spike before every P wave in each complex. So I know that this rhythm is atrial paced. The second rhythm here is AV paced or atrioventricular paced. And I know that because I see a pacemaker spike and then I see a P following it. Then I see a pacemaker spike, then I see a QRS. And this continues for each complex. Pacemaker spike, P wave, pacemaker spike, QRS. So this is an atrioventricular paced rhythm. And every complex following each pacemaker spike that we've seen so far has a complex following it. That means that there is capture. So when the pacemaker fires, the heart is capturing that rhythm. So this is a good thing. And by the way, a QRS complex will be more wide if a patient has a ventricular or an atrioventricular paced rhythm. We expect that. The third rhythm here is ventricular paced rhythm. And we know that because there's a pacemaker spike followed by a QRS, a wide QRS. Pacemaker spike, QRS, pacemaker spike, QRS, and it's only pacing in the ventricles. We see the ventricular pace rhythms typically in emergency situations. They will prescribe it to be ventricular pace because that's how those work. And that way we get perfusion in those types of situations. Okay. So temporary pacemakers include things like transcutaneous and transvenous pacemakers. So a transcutaneous pacemaker is across the skin. So this is non-invasive. This is when a patient is doing poorly, maybe they're symptomatic bradycardia, and we get the crash cart and we will attach them to the defibrillatory pads from the crash cart, and we will set it and plug it into the monitor there, the defibrillator monitor. But we will make the settings say pace on them, so that way we can pace the rhythm. We will set a prescribed pacer heart rate that the physician says, set this heart rate to 60, and we set it to 60, and then we will select the amount of energy or milliamps that until we see capture in the pacemaker. So this is great. These are a great temporary option for patients that are doing poorly with a low heart rate or other rhythm that's not perfusing well. This is painful for a patient because it's an energy jolt going through their skin, so it doesn't feel good. Usually we like to give them a little sedation to tolerate this procedure. If we know that the patient needs eventually a permanent pacemaker, or we're just not doing well with this transcutaneous pacemaker, another thing that we could use is a transvenous pacemaker. A transvenous pacer is more invasive because it goes transvenous, so across the veins. It goes into their neck typically, into their jugular, and then it goes into their right atrium, and it terminates in that right ventricle. So this internally places the pacemaking wires. So it actually paces the heart from the inside. But it's temporary because it's in their neck and it's attached to this little box. So this is temporary. These are great. Both of these are only for emergency use. They're done in synchronous mode, typically in the hospital environment only. For the transvenous pacer, this is inserted usually as a bridge until we can get the patient to get a permanent pacemaker. So here's what they look like. So the transcutaneous pacemaker, as I mentioned, you're going to sandwich the patient. So they're going to have that defibrillatory pad in the front and one on the back, and then it attaches to the monitor. And we're making sure that once the heart rate is set and the energy is set for the patient with the transcutaneous pacemaker, that there is a complex following every pacemaker spike, and that we are making sure they have a pulse to match. So we're always checking pulse and always checking the status of our patients. Are they hemodynamically stable? Are they mentating well? Level of consciousness good? What's their skin look like? Are they cap refill? Is that impaired? We're always checking these things on the patients because they should be perfusing well when they have a pacemaker. The next picture is a transvenous pacemaker. So as I mentioned, it goes down into the heart and it's into the right ventricle. You'll see this little box at the bedside, often on the patient or at the head of the bed. And you can see where the heart rate is prescribed at 70 here. So that's set at a rate of 70. And the energy or the output or MA or milliamps is set until the patient gets captured. And then there's a sensitivity that's prescribed by the physician as well. So we make sure that everything is plugged in, hooked up, good battery, and the patient is lying there without moving it around, because it's important that they tolerate this so we can get their heart rhythm to work. There's a clip here for you to watch. It's just how to do transcutaneous pacemaking. Okay, so for permanent pacemakers, which are seen here, they are a permanent solution, not temporary. It's treating a conduction disorder that's permanent. So these are battery powered and they're rechargeable. They usually last about 10 years. And this is a surgical procedure. So these are actually implanted into the patients. The procedure usually takes about an hour. And these are for things like a third degree or a complete heart block, or a second degree heart block like a type 2, or for patients that their heart is just not going as fast as it should. So we need one of these to perfuse. Always, always, always assess your patient. So before they get a permanent pacemaker, we're getting our baseline neurologic status so we know what their level of consciousness and how they usually mentate. We're checking their vitals. We're checking their cap refill, their skin color, their blood pressure to see what it is at baseline, and then during the procedure and after. Patients are usually symptomatic before they get the permanent pacemaker. So after we get the permanent pacemaker placed, we want to make sure that that patient is experiencing less symptoms of hemodynamic instability than they did before the pacemaker. The pacemaker is generally planted in the left upper chest. You'll see it in the right upper chest. They can be in the stomach if needed, but usually they're in the left upper chest in like a little subcutaneous pocket in the pectoral region, usually under the clavicle. And for a woman, they try to put them below or behind rather the breast. The procedure, again, takes about an hour. We'll sedate the patient. They'll have local anesthesia, so it doesn't hurt when they wake up. And they'll also have like a moderate sedative or conscious sedation. We're monitoring them during the procedure, particularly from a respiratory perspective, because we want to make sure that these patients are are oxygenating well. There can be different types of chambers that we place the pacemaker in. Generally, we'll either see a single lead pacemaker or a double lead pacemaker. So for a single lead or a single chamber pacemaker, this is when one lead is placed in either the right atrium or the right ventricle. This is often used for like a slow rhythm or like a slow AFib for those who also have ventricular dysrhythmias. There are dual chamber or double lead pacemakers, and this is the most common type. And you'll see this has two leads, one's in the right atrium and one's in the right ventricle. So this helps to regulate the timing of the impulses that are delivered. So pre-procedure, if you're taking care of a patient that is scheduled for a permanent pacemaker placement, before the procedure, they must be NPO for 8 hours. Again, get their baseline, always know what they are like before a procedure so you can have something to compare to them after. Baseline EKG, baseline vital signs, baseline neuro status. You're letting them know all the information they need to know ahead of time. You may have to prep and shave the generator site area, so whatever area they're going to insert it in may need to be prepped by you. And you'll need IV access because they're going to need some medication like sedation. And if something goes south, at least we have IV access. During the procedure, we're going to continuously monitor the cardiac rhythm. They will be moderately sedated, so during the procedure. So then afterwards, as they're coming out of the procedure, we're making sure that we're monitoring their neuro status, their vital signs, always checking a pulse to make sure that the rhythm on the monitor matches our patient and that they are no longer in distress after the procedure. Assessments, you're going to assess their level of consciousness, again, a full EKG, vitals. If they have pain afterwards, we might need to give them some more analgesics to make it more comfortable. They just had a procedure done. We're going to look at the site and assess it for bleeding and assess it for infection. Report any evidence of infection or bleeding right away. We are going to teach the patient that they need to restrict movement of that right arm for at least 48 hours after the procedure. Often we'll put them in a sling to remind them not to lift that right arm afterwards, because if they lift that right arm afterwards, this pacemaker is new to their body. It's not seated where it needs to be, like in a permanent position, because it's, the body's still adapting to this invasive instrument in them. So we make sure that they don't move that arm because they could dislodge that pacemaker, and then we're in trouble. So after the procedure too, they'll get a chest X-ray to confirm it's in the right spot. Discharge teaching for a patient. We're making sure after they are discharged that they know what kind of pacemaker they have and that they're very, very well aware of all the information and what it does, and that they have a copy of it on them, and that their family member has something saying what type of pacemaker they have. We're going to teach them to monitor their site for bleeding and infection and tell them not to swim or really submerge that area for 3 full days. They can shower, but their back needs to be to the shower, and there should be a tegaderm over the site if they do get in the shower. There will be steri strips, and they'll come off in about a week. That happens. We expect it. Limited range of motion of that affected arm, and they should wear like loose clothing for about a week, so nothing constrictive to that area, so that way we can heal. They should avoid heavy lifting, so anything greater than 10 pounds, they can't lift for about 4 weeks, or until they are told by their provider that it's safe to lift again. No contact sports for these patients, and they should tell their physician right away if they are developing any palpitations, any like weakness or anything of the symptoms that they had before the pacemaker was placed. They need to do their follow-up visit, and they should always wear a medic alert bracelet or some type of indicator. The pacemaker information should be with them at all times. And know that this pacemaker can trigger alarms like airport security. So if they're planning any trips or anything like that, they'll need to contact the airport before they travel, so that way things can be arranged before they get there at the time that they're traveling. These patients will not be able to get MRIs any longer because magnets and things like strong magnetic fields will flip the pacemaker into a different delivery. So that, in other words, we don't want them near anything magnet because it's going to interfere with that pacemaker. So no MRIs. Cell phones, they have a magnet in them typically. So we tell patients, like this man in the picture, if he wants to talk on his cell phone, it should be greater than 6 inches away from that pacemaker because it can interfere. So they can talk on the opposite ear if they need to. No smartwatches, because you keep your hand up to your head and that smartwatch can interfere with that pacemaker, and then they've got a problem. So we avoid smartwatches in these patients as well. These patients, if they do get dizzy near any type of electric device, like a microwave or like some heating ovens, some conduction ovens, I think they're called, things like that, patients need to, they'll know because they'll have the information ahead of time, depending on what type of pacemaker they have. But should they feel dizzy or any symptoms when they're near an electronic device or an electrical device or any cooking things that submit a lot of or emit a lot of energy, they should get away from that if they feel dizziness, and they should sit down so they don't fall. So that's important. They should every day be taught to monitor their own manual heart rate, and they should do this every day. And if there's any discrepancies between what the pacemaker is set at and their felt rhythm, they need to contact the physician right away. Never can we put any medication patches like a nicotine patch or pain patch, anything, never anything over top of that pacemaker. It's off limits. So if we had to defibrillate this patient, if there was an emergency, we don't put the pacemaker, the defibrillatory pads on top of that pacemaker. So never do that. If we look on the heart monitor and we happen to see, we have a picture of it here, yes, if we see failure to capture, then we need to act. So what that means is if we look on the pacemaker, on the rhythm strip, and we see a pacemaker spike, but we do not see the complex following it. So in this case, this is a ventricular paced rhythm. If we see a pacemaker spike and no QRS afterwards, or like you see how many that this patient is missing, looks like they have one missing, then they have a beat, then they miss two, and then they have a beat that's paced, and then they have a pacemaker spike with no QRS, and so forth. If we see this failure to capture, this is a big deal. The first thing we do if we see this in clinical practice is we will check our patient. So we always check our patient, believe the patient, check for signs of decreased cardiac output. So low blood pressure, paleness, sweating, fatigue, chest pain, palpitations, dizziness, syncope, anything like that that indicates low cardiac output, we're checking for. And we're looking at their EKG for the pacer spikes to make sure that they do have a heartbeat after, like a heartbeat after the complex, after the pacer spike. If we don't have this and we see pacemaker spikes, no QRS, the patient's symptomatic, or even if they're not, we're still going to contact the physician so that way they're aware. They may need to interrogate or reset this pacemaker. And we always should be prepared in the case of an emergency for transcutaneous pacing. So if this is a patient in this picture, for example, that a patient has a transvenous pacer or a permanent pacemaker, something may have become dislodged, and we need an emergency backup. So I remember once we had a transvenous pacer in a patient, and someone came into the room and they tripped over the cord where that box is that connects to the transvenous pacemaker, and it dislodged the pacemaker completely. So immediately we had the crash cart outside of the room, so we hooked them right up to a transcutaneous pacemaker, and we're able to save the patient quickly. So always be prepared to transcutaneous pace in the event of an emergency, or if the patient becomes hemodynamically unstable, we have that transcutaneous pacer as a backup. So that's good. We're going to always document our findings if this does happen and make sure that someone is aware that the pacemaker is not capturing. Okay, so the next part and the last part of this presentation is implantable cardioverter defibrillators, or ICDs. These are great. These are like the patient's own defibrillator, like we usually use on a crash cart. If a patient is in VTAC or VFib, we use a defibrillator on the outside and we shock them. We stay clear and then we shock them. In this case, the patient has one of those implanted inside of their chest. And they can, these ICDs can also be like a combo, like a combination ICD/pacemaker. So they're really great. These are recommended and, promoted for patients that have LV or left ventricular dysfunction, severe LV dysfunction. So if their ejection fraction is 30 to 35%, they are at high risk of just sudden cardiac death because their heart is not working correctly. It's not ejecting the blood from that left ventricle and perfusing the body the way it needs to. So these patients will need an ICD. So patients, again, ejection fraction less than 30 to 35%, they're at risk for sudden cardiac death. So they need an ICD. And this will deliver a shock or a charge in the event of a dysrhythmia. So if they have VTAC or VFib, it will shock them and restore their heart to a normal rhythm. Some patients may feel this fluttering in their chest when they have it. Some patients feel it very strongly if they get a shock, if they have an ICD placed. They're encouraged if they feel any type of shock or fluttering in their chest that they sit down. Very important to sit down because safety is key. And if these patients are getting shocked, they need to protect themselves from injury because they can fall. If they continuously get shocked, they can fall. So we'll make sure that we tell them to sit down. If a patient gets multiple shocks, they'll need to go to the emergency department because they may be, their heart is really failing. So again, if they get a shock, this does happen, sit down, see if it happens again, stop the activity, don't hurt yourself. And if you continuously feel shocks, you need to go be seen. Sometimes they will get a shock. Some people get a shock every other day. But if it's continuous or, whatever, they need to be seen by the provider. That's all for this presentation. If you have any questions, please reach out and have a great rest of your day.